is our agenda for today. We're going to go into basic concepts of sleep first, and then we'll go into the health issues. And lastly, I'll go over some common sleep disorders, and I'll leave plenty of time for question and answer. And at any time, if there's any questions or anything that's not clear, please let me know. Okay, so let's see. We'll start off by defining sleep. Oh, sorry. Let me go back to. Okay, so you see the book right there. That's the principle and practices of sleep medicine, and that's considered the Bible of sleep medicine. And these are the three authors. Okay, so according to the Bible, sleep is defined as a recurring, reversible neurobehavioral state of relative perceptual disengagement from and unresponsiveness to the environment. Sleep is typically accompanied by postural recumbence, behavioral quiescence, and closed eyes. Okay, but nobody understands that sentence. So the simpler explanation would be, and this comes from the Webster Dictionary, the natural state of resting, which your eyes are closed and you become unconscious. Much simpler. Okay. And definition of health. And this comes from WHO. State of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And this is important. Most people think health is really just free of disease, but you actually have to have both the physical, mental, and social well-being. And sleep health, in a way, is a combination of these two concepts, but it's a hotly debated sort of definition. And the reason being, I'm not going to read that to you, nobody really understands what it says anyway. The reason being is we haven't really figured out what's the exact function of sleep. There are multiple theories as why humans and animals sleep. The most obvious one is the restorative and somatic growth theory. Okay, this is when you sleep, that's when the growth hormone is released, and that's when the body repairs and sort of build up. And the next one would be the metabolic theory. It makes sense that when you're sleeping, you're conserving energy as opposed to when you're awake. But in fact, you don't really conserve that much energy when you're sleeping compared to when you're just lying in bed awake. I think the overall saving is about a piece of a toast. So that's definitely not the main reason. Also, and this is actually the most recent theory. You remove the toxins that's produced in the brain during wakefulness. In a way, it's time for the brain to do house cleaning. And it's surprising because before 2 years ago, we never knew that brain has a lymphatic system like the rest of the body. But recently it's been discovered brain does have its lymphatic system. It works only at 10% when you're awake, and it becomes fully functional when you're sleeping. And this actually runs across all animal kingdoms. So that's probably the most important reason why we sleep. There are two other theories. One is a sort of survival theory that comes from evolution. You really shouldn't be running out of your caves in the middle of the night because it's dangerous out there. It's not as obvious now, but back then it was very important. And the neural growth and processing theory. In the past, sleep hasn't been excluded, confined as a brain process. Of course, it does help the body rest. But we have since recognized it's mainly a neural process. And it's time for the brain to develop, to restore, to consolidate memory, and this process allows us humans to be different from sort of animals. Okay, all right, and I'm going to go into the different stages of sleep next. Sleep is usually divided in two categories. One is the non-rapid eye movement. You go from stage one, which is just drowsiness. You usually shouldn't lasts more than about 5% of the total sleep. Stage 2 is considered light sleep, and that accounts for a majority of the sleep, 50 to 55%. And stage 3, that's considered the deep sleep, slow wave sleep. It used to be 3 and 4, but it only mattered, but now they have changed it to just stage 3. That's about 20%. And then the other sort of category is the rapid eye movement sleep. That's usually considered the sort of the dreaming stage. However, you actually do dream in all stages. It's just that when you're wakened from REM sleep, 98% of the people will report that they're dreaming, as opposed to the other stages, maybe only 50. And also during REM sleep, your dream is more visual. And in the other stages, it's more of a thinking process. So a lot of times you're awakening from stage 2 sleep, you may not think that you're sleeping, but based on the brain wave that you actually are. And there's always that argument, which is the deeper stage of sleep? Is it N3 or is it rapid eye movement? In some sense, the N3 is deeper because it's harder to arouse. And the EEG looks vastly different from the wakefulness brain waves. And during REM sleep, it's easier to wake up. And it's actually, you feel better when you wake up from REM sleep. However, during REM sleep, you lose your muscle tone, so you don't move at all. And you lose your temperature control. And this is sort of significant in children because if you don't have temperature control, you tend to get sicker quicker. And also, the stages, I'll show you a diagram, but basically the non-REM sleep predominates in the first half of the sleep, and that's where N3 is. So if you go to bed too late, you're actually missing part of the N3 sleep, and you don't make that up. Maybe the next night. So it's actually important to go to sleep early. All right. And then REM is sort of toward the second half of the night, and that's why most people wake up, dreaming. Okay, so this is the sort of normal sleep architecture. It's actually a cycle of about 90 minutes. You go from stage 1 all the way down to 3. This is the old diagram, so it still has 4 in it, but usually on 3, and then you cycle back, and then you hit REM, you go deeper again, and then you come back. So each cycle is about 90 minutes. And the way we're determining the different stages is by looking at the EEG. This is just a sample. The top is awake, looks very sort of squiggly, and as you go down, you see the wave become larger and larger. And on the bottom, that's REM sleep. And it looks very similar to when you're awake. Okay. And this is a sample of the PSG. That's what the sleep. That's when you go to do a sleep study, and this is what they record. It records eye movement, the first 2 channels. It records sort of brainwave activity. It looks at chin muscle tone. It looks at the heart. It looks at breathing, airflow, and leg movements. And this is only a 30-second echo. And supposedly, if you sleep 6 hours, that's 360 minutes. And so there's 720 of these epochs you have to go through. This is the most boring stuff to read, and I think it puts everybody to sleep. Okay. And this is the sleep architecture over the lifespan. Even though this only accounts from 5 to 50, but the trend follows all the way up to 80 and even 100. So as you get older, the stage 2 stays relatively stable. It's the slow wave sleep that decreases. REM sleep decreases slightly, and then there is WASO. This is wake after sleep onset, meaning how much time you spend awake after you have gone to sleep. That has also increased. And sleep latency does take a little bit, slightly longer to fall asleep. but not much. So it's just like anything in the body. The knee, the lung, the kidney, they don't function as well. So you don't. As you get older, sleep is not as good as you were younger. Okay. Briefly, we'll go. There are two. Sleep is controlled by two intrinsic processes. One is the biological clock. You're more awake in the late morning and early evening, and you're more tired in the early mornings, 4 or 5, and in the mid-afternoon. That's why people feel tired. Not because, a lot of people attribute it to food coma after eating lunch, but it's actually your biological clock that makes you tired around 1 or 2. The other control is sleep homeostasis. Basically, it just means the longer you're awake, the tired you are. And it has to do with buildup of a chemical called adenosine. And that's exactly what caffeine blocks. And then there are also two other systems. One is the arousal system. It works independently from the sleep process. And interestingly, with insomnia, people used to think it's a sleep-related issue. But now we know insomnia really not a sleep problem. It's more of an arousal system issue. And lastly, and this really mainly seen in humans, is the behavioral control. Even though you're tired, your biological clock wants you to go to sleep, but you can always force yourself to stay awake to do things. Watch TV, play with your phone, and etc. Okay. And this is a simple diagram of how brains controls the sleep system. The SCN, the circadian clock, that's the master clock, and controls. And every organ in the body has its own intrinsic clock, but it's controlled through the SCN. Okay, so and this is really one of the most frequent questions people ask: how much sleep do I need? And it's age dependent. And this is the recommendation coming from the Sleep Foundation just 2 years ago. And when we're looking at sort of from adult to older adults, it's most people need it between 7 to 9. Younger people need it closer to 9 than 7, and older people need it to 9. So the common belief that you need 8 hours of sleep, even though it's not exactly correct, but it's actually a good estimation. When you get 8 hours, you're sort of in the middle. So you're not really getting too little sleep. You may need more, but 8 hours actually is a good hours to strive for. Okay, so what's considered poor sleep? There are 3 things that we look at. One is when you don't have enough hours of sleep, and when you have poor quality, and when you're sleeping at the wrong time. Okay, and I'm going to, when you have poor sleep, what we know about the diseases in connection with sleep. First of all, we know that working night shifts increase the risk for a lot of cancers. Some of them don't seem to be as affected, but breast cancer, bladder cancer, colon cancer, lung cancer, pancreas, prostate, and non-Hodgkin's lymphoma are related to working night shift. And actually, working night shift has been called as a carcinogen by World Health Organization. And there is a twofold increase in the risk of prostate cancer in men with insomnia, 50% increase in colorectal cancer for people that sleep less than 6 hours. And postmenopausal women, even though they have a lower chance of getting breast cancer once they hit menopause, but if you have insufficient sleep and you do get breast cancer, they seem to be the more aggressive form. And then sleep disorder, obstructive sleep apnea, is associated with a more aggressive form of melanoma. And the reason why we think sort of cancer risk is increased in shift workers, it's about exposure to light at inappropriate times. And because of that, 2 things happen. One is it alters cortisol rhythm, and cortisol is a hormone that regulates the immune system. And the other one is melatonin. It's another hormone that sort of regulates the biological clock. It's what we use to treat jet lags. It's also an antioxidant. And when you have light suppresses melatonin, and when you don't have enough melatonin, you don't have that antioxidant function. Both of them suppress estrogen, so I think that's what leads to breast cancer. We have more study on breast cancer than other cancers, so those we know. And we know it's definitely light related because we see a decrease in cancer risk in blind people. And there's a greater decrease compared to people with just severe visual impairment to complete blindness. So even getting a little bit of light does increase at the wrong time, does increase your cancer risk a little bit. Okay. And sleep and heart disease. Well, the number one cause in the U.S. Mortality is heart disease. And the most disabling, the number one disabling disease actually across the world is stroke. And both of them are related to sleep. So people that are short sleepers so both short sleepers and long sleepers have increased chance of heart disease and stroke. A short sleeper is defined by less than 6 hours a night, and long sleeper is defined by greater than 9 hours a night. And the increased risks are 48%, 38%, and 15%, 65%. There's some controversy in why, if you sleep too long, you also are at risk for heart disease. And we think it's not the amount of sleep itself, but more what's associated with long sleep. These are people that are more obese, they exercise less, they may be smokers, drinkers, and that's what causes the increase in stroke and heart attack. And poor sleep causes an obstructive sleep apnea, which is when you sleep, you stop breathing. They're linked to obesity, and it's caused by dysregulation of two hormones, leptin and ghrelin. And when people have poor sleep or sleep apnea, poor quality sleep, they tend to eat a lot, and they tend to pick high-calorie foods. And lastly, sleep apnea is an independent risk factor for stroke and heart attack. It causes the development of hypertension, diabetes sooner. And the recent studies showed if you have sleep apnea untreated, even if you have a stent for the heart, your risk for heart attack still increases. Okay, so lastly, we're going to talk about dementia and sleep. And there are multiple types of dementia. These are the more common ones: Alzheimer's disease, vascular dementia, dementia with Lewy body, frontotemporal dementia, and includes Creutzfeldt-Jakob disease. That's the mad cow disease. All right, so Alzheimer's disease is the most common. It accounts for 60 to 80% of all dementia. It's a gradual progression. Sleep disturbance is very common, and you can usually see disturbance in the beginning, along with some memory loss. And we believe the mechanism behind this is when you don't sleep enough, you don't clear out the toxins from the brain, and you have what's called the beta amyloid plaque that builds up, and that's really pathognomonic for Alzheimer's disease. But also, we think it's possible these plaques, that's causing the disturbance in sleep. But regardless, treating sleep in Alzheimer's disease does help stabilize the disease progression. The second most common type of dementia is called vascular dementia. And it differs from Alzheimer's disease in that it's a quicker onset and usually a stepwise progression. You can be stable for some time, and all of a sudden your cognitive dysfunction drops, and then you start with a new baseline until it drops again the next time. And it's usually caused by strokes, damage to the brain vessel, blood vessels in the brain, and it has the same risk factors as hypertension, diabetes, cholesterol, and sleep apnea. Okay. lastly, dementia with Lewy body, that's the third most common type. And what's interesting about this disease is it has a very specific sleep disorder called the REM sleep behavior disorder. Normal sleep, when you're dreaming, your whole body is paralyzed except the breathing muscles. But in REM disorder, you actually lose that inhibition. You act out your dreams, you punch your sort of bed partners in the face, you kick them, and this sort of pathognomonic for dementia with Lewy body, and you treat it with sedative or melatonin. Okay, so I'm just going to go into some common sleep disorders. Let's start with insomnia. Okay, so that's a cartoon of insomnia. And the criteria, so for insomnia, basically there are three types. There is trouble initiating sleep, trouble maintaining sleep, or waking up too early. But that's not enough. You actually have to have dysfunction along with these difficulties. So basically, you must be feeling tired, you have trouble with memory, concentration, you have social dysfunction, poor school performance, mood disturbance, daytime sleepiness, energy reduction, motivation reduction, you're prone to errors or accidents at work or driving, or tension headaches or systemic symptoms. So these are not only criteria, but these are also the consequences of insomnia, and that's what we normally see. And we can categorize insomnia by different ways. One is by duration. Anything less than 2 weeks is transient, and this happens to everybody. When you're ready to interview for a new job, when you have a test to study for, it's very common. It really doesn't need treatment if it's transient. Another form would be intermittent. That's also quite common. With any kind of social stressors, transient, intermittent insomnia is very common. It's only when it becomes chronic that's when people start seeking medical treatment. And this is defined by continuing difficulty with sleep for at least 1 month. But by the time they get to me, it's usually years of trouble sleeping. And also, you can define insomnia by etiology. The primary insomnia, basically, it's genetic. We don't know, there are no secondary causes, just like primary hypertension, people just get blood pressure when they get older. Then sometimes there are causes, but other times it's really primary. And insomnia can be due to any kind of medical or neurological issue, any kind of psychiatric issue. Medication and drugs can cause insomnia, and also there are other primary sleep disorders that can cause insomnia as well. And by the ICSD, that's the classification, the International Classification of Sleep Disorders. There are different types, and some of them I mentioned. The most common is the psychophysiological insomnia. It's the one that you lie in bed awake, worry about things, planning the next day, worry about your kids, grandkids, and after a while you start getting the fear of sleep because you lose the confidence that you're able to fall asleep. So by the time the nighttime comes, you start getting anxious, and this anxiety also fuels the worsening insomnia. And the other one that's kind of interesting is the paradoxical insomnia. This is initially called a sleep state misperception. Basically, you feel like you're not sleeping at all, but when we take you to the sleep lab, you're actually sleeping throughout the night. And before we thought it's a misperception on the patient's part, but recent studies showed the patient's actually right. It's the doctors that were wrong. So even though it looks like they're sleeping, but their brain waves has a lot of wakeful spikes that's going on. And so they're really not in the normal sleep as most people sleep normally are. Oh, and I mentioned before, insomnia is not a problem of sleep, but rather a problem of hyperarousal state, your biological clock still functioning normally, and your adenosine buildup is still normal. So the longer you're awake, the more pressure for sleep there is. You really have to work on really decreasing the arousal state. Okay, so in the psychophysiological insomnia, this is sort of a basic model. Everybody has a baseline for insomnia. And the first one is sort of primary insomnia. These are the people that, even without any stressors, they just have trouble sleeping. That's genetic. Nothing we can do about it at this time. Most people have a below threshold sort of insomnia intensity, and that's the yellow bar on the bottom. And when you have an acute stressor, it pushes you over the threshold. And that's what causes acute insomnia. But you see, as the orange bar decreases, some people still get short-term insomnia because while they're in the acute period, they develop wrong ideas of sleep or wrong behavior, such as worrying too much in the bed or try to force themselves to sleep, which is counterintuitive. But forcing yourselves to sleep is the worst thing you can do. And lastly, it progresses to chronic insomnia. Basically, the initial stressor is almost gone. You have really low baseline of insomnia. It's really that sort of the perpetuating factors, the cognitive behavior aspect of insomnia that's keeping you awake. Okay, so we all know if you have insomnia, you take Ambien, you take Lunesta. That usually works. It's actually a good medication. It's good for about 6 months. Okay, more than that is really not. Even though there are no physical or psychological dependence, but it does have some long-term consequences. People on long-term sleeping pills tend to develop dementia earlier, and even low-dose Ambien is shown to cause increased risk of brain tumor, like the benign type. You don't want brain tumor regardless. So when people come to me for sleep, for insomnia, I usually try to stress the non-pharmacological therapy, so you don't get all the sort of long-term sequelae. And the common ones: relaxation, biofeedback, yoga, meditation. Imaging training is actually the most studied technique nowadays. Basically, take your favorite movie, the movie that you know very well. It's nothing that's too exciting, too gory, too violent. Okay, imagine yourself being the main character in the movie. So you think through the movie, and as long as you're following the plot of the movie, you won't think of anything else. And this builds on the principle that brain is not a computer. It doesn't do two things at a time. So as long as you can occupy the brain with something, you're easier. It's easier for you to stamp out all the worries, all the concerns. Of course, it doesn't work right away. You still have to sort of keep trying and keep trying. This is the same way we count sheep when you can't sleep, but this is much easier to do. Acupuncture, that's also a good way of treating insomnia. Okay, so quickly, obstructive sleep apnea, that's other than insomnia, this is the other most studied disease, because mainly it has consequence in terms of heart disease, which is the number one mortality in the country. Okay, so the symptoms are snoring, and these you will recognize. Snoring, wake up choking, and people see you stop breathing. You feel like you never had a good sleep. You wake up multiple times to go to the bathroom. And with older people, sometimes the prostate issue, but once you rule that out, sleep apnea should be considered, and you wake up with dry mouth and sore throat. And when you have sleep apnea, it's the same symptoms that you have when you don't have enough sleep. So if you're tired during the day, you wake up with headaches, you have poor memory, concentration, poor work efficiency, and it's connected to depression. And in terms of safety,